Hello everyone, and welcome to Vet Image Lab. When we think of ultrasound artifacts, we often see them as errors, something to be avoided or corrected. But many artifacts actually help us make more accurate diagnoses. Instead of simply avoiding artifacts, we're going to learn how to recognize, understand, and even use them to improve our diagnostic accuracy. Let's get started. There are many types of artifacts, but in today's lecture, we will focus on the 10 most essential ultrasound artifacts that you must know include acoustic shadowing, edge shadow, reverberation, acoustic enhancement, mirror image artifact, slice thickness artifact, side lobe artifact, echo dropout, blooming artifact, and twinkling artifact. To fully understand these ultrasound artifacts, it's important to grasp the principles behind how ultrasound images are generated. For those who want to review the basics, I've included a link in the top right corner to our previous lectures. Now, let's take a closer look at each artifact and see how we can use them to improve diagnostic accuracy. Acoustic shadowing occurs when ultrasound waves encounter a highly reflective surface like bone or gas. This results in a dark shadow behind the object, as seen in the left image. This is a classic example of acoustic shadowing. Notice the bright echo from the gas in the small intestine, marked by the yellow arrow. The gas causes a strong reflection of the ultrasound waves, resulting in a dark shadow beneath it. This is another example. We see multiple hyperanechoic calculi in the urinary bladder, each generating a distinct shadow. Recognizing this pattern is crucial for correctly identifying calculi in various organ systems. Looking at this ultrasound image, we see round-shaped structures in the gallbladder. Could these be bile stones? Normally, bile stones are expected to produce a shadow distal to their location due to their density. However, in this image, we do not observe any shadowing behind the round structures. This absence of shadowing allows us to rule out bile stones. Instead, what we are likely seeing here are bile balls, which do not typically generate acoustic shadows. Bile balls are aggregates of bile material that are softer and less dense compared to stones, and usually don't create acoustic shadows in ultrasound images. Clinically, bile balls may not cause symptoms, so it's important to differentiate them from bile stones. Moving on to our next ultrasound artifact, the edge shadow, also known as shadowing by refraction. As shown in the diagram on the left, when ultrasound scans a rounded structure, the beams that passing through the non-curved areas continue on their path without deviation, while the beams that pass through the curved edges of the object are refracted. This refraction at the edges causes a significant reduction in the intensity of the ultrasound waves, creating a shadow known as an edge shadow behind the curved edges. In clinical practice, edge shadows are commonly observed in normal and abnormal structures on ultrasounds. Here's a typical example. When performing an ultrasound on the gallbladder, we can commonly observe the edge shadow from the edge of the gallbladder. It's important not to confuse these edge shadows with the acoustic shadows that gallstones create, while both might appear similar as dark areas on your ultrasound. Remember, edge shadows are simply due to the gallbladder's shape and generated from the curved edge. In this image on the right, we have a patient with ascites, where you can clearly see segments of the intestine. Notice how edge shadows are forming from the rounded edges of the bowel loops. In the left image, we observe a normal kidney, where edge shadows are visible. These artifacts are generated from the curved surfaces of both the external renal capsule and internal structures, like the renal sinus and pelvis. It's important to note that these shadows, which result from natural curvatures, should not be confused with the shadowing artifacts generated by renal calculi, as seen in the right image. Let's talk about reverberation artifact. In cases where there is a large amount of gas, like in the left image, ultrasound waves encounter gas bubbles and get reflected multiple times before returning to the transducer. These repeated reflections result in multiple bright, linear echoes that appear as evenly spaced, parallel lines. We see an example of this artifact in a gas-filled intestine. The ultrasound waves are reflecting multiple times within the gas-filled area, producing the characteristic bright, parallel lines. Since reverberation artifacts primarily occur at highly reflective interfaces, they are commonly seen with gas or metal. Before we move on, let's take a step back and think. In gas-filled areas, we can observe both acoustic shadowing and reverberation artifacts, depending on how the ultrasound waves interact with the gas. As you can see in this image, some areas distal to the gas appear dark due to shadowing, when most of the ultrasound waves are reflected, while other regions show bright, repetitive echoes due to reverberation, when sound waves bounce multiple times between gas bubbles. Understanding these differences helps in distinguishing artifacts and avoiding misinterpretation in clinical practice. Next is the Enhancement Artifact. This artifact presents as an area of increased brightness directly behind fluid-filled structures. When sound waves pass through these structures, there is minimal absorption or dispersion because fluid-filled structures have low attenuation. As a result, the waves maintain a higher intensity when they exit these structures compared to when they pass through denser tissue, leading to a brighter display on the ultrasound image. In this ultrasound image of the gallbladder, you can clearly see the Enhancement Artifact. Notice the area of increased brightness directly behind the gallbladder. The Enhancement Artifact can be used to differentiate cystic from solid lesions. In this image, notice a dark structure in the liver. You can observe increased brightness directly behind the lesion, indicating that the lesion is fluid-filled. This enhancement helps us confirm the cystic nature of lesions. Here's another example that illustrates the diagnostic use of the Enhancement Artifact. In this ultrasound image, we see a dark structure within the mid-abdomen. Notably, there is no increased brightness behind this structure. The absence of posterior enhancement here confirms that the lesion is not a cyst. This is a thickened bowel wall, a common presentation of lymphoma. In this next example, we're examining an ultrasound image of the spleen that displays multiple hypoechoic nodules. Initially, one might suspect these to be multiple cysts because of their appearance. However, in cases of true cysts, we would typically observe clear enhancement due to their fluid content. The absence of such enhancement in this image allows us to confidently rule out cysts, and instead diagnose these nodules as manifestations of lymphoma in the spleen. We must be cautious not to misinterpret artifacts as pathological echo changes. In this patient, notice the focal increase in the cortical echoes of the kidneys. An inhomogeneous renal cortex with focal hyperechoic changes might initially be mistaken for a pathological finding. However, in this case, a significant amount of ascites generates Enhancement Artifact, which is responsible for increasing the focal cortical echoes. Understanding how fluid-induced artifacts can alter ultrasound images is essential to avoid diagnostic errors and ensure accurate interpretation. Now, let's talk about a mirror image artifact. To better understand this artifact, let's use the liver and gallbladder as examples. When an ultrasound wave encounters the gallbladder, it reflects off its surface, and these reflected waves return to the transducer to create the ultrasound image. So like in this image, the liver appears above the hyperechoic diaphragm. However, in certain cases, instead of traveling directly to the gallbladder, some ultrasound waves first reflect off the highly echogenic diaphragm. Then, the redirected waves travel toward the gallbladder, and the waves reflect off its surface. The reflected waves from the gallbladder then return to the diaphragm, where they are reflected again, before finally reaching the transducer. Since the ultrasound machine assumes that all returning echoes travel in a straight line, it mistakenly interprets the delayed echoes as if they are coming from a deeper structure. As a result, a mirror image of the liver or gallbladder appears on the other side of the diaphragm. This artifact is particularly common when scanning near highly reflective surfaces like the diaphragm. Here's an example. In the left cranial abdomen, we can see a hypoechoic leiomyoma in the stomach. However, due to the mirror image artifact, the same structure appears again below the diaphragm. This duplicated image is not a real lesion, but an artifact caused by sound waves reflecting off the diaphragm before returning to the transducer. Recognizing this artifact is crucial to avoid misdiagnosing an additional mass in the thoracic cavity. This is another example. In this case, the liver appears above the diaphragm as expected, but due to the mirror image artifact, an additional liver shadow is seen below the diaphragm. In a mirror image artifact, the duplicated liver image appears symmetrically above the diaphragm, but it lacks continuity with the actual liver parenchyma. The diaphragm remains intact, and the false liver image does not show independent movement. However, this artifact should not be mistaken for a true diaphragmatic hernia, where the liver actually herniates through a defect in the diaphragm and is located below it. Let's look at a case with a diaphragmatic hernia. Here, the liver is genuinely located below the diaphragm. The displaced liver does not have a symmetrical appearance with the original liver, and it is accompanied by an anechoic structure below the diaphragm, which represents the displaced caudal vena cava. As you can see, when you carefully adjust the probe angle while scanning the diaphragm, there is a defect in the diaphragm, and part of the liver extends through a defect in the diaphragm, maintaining direct continuity with the intra-abdominal liver. This is an actual anatomical displacement rather than an imaging artifact. Recognizing the difference between a mirror image artifact and a true diaphragmatic hernia is crucial to avoid misdiagnosis. Now, let's talk about slice thickness artifact. Unlike a single thin beam, the ultrasound wave has a certain thickness. Slice thickness artifact occurs due to this inherent nature of the ultrasound beam. When the ultrasound beam includes both an anechoic fluid-filled structure and adjacent echogenic tissue within its thickness, the returning echoes from both structures are averaged together. As a result, instead of appearing as a purely anechoic area, the fluid-filled structure may give a false impression of debris or a solid component inside a cystic structure. A common example of this artifact occurs when imaging fluid-filled structures such as the gallbladder, urinary bladder, or cysts. Instead of appearing completely anechoic, these structures may show faint internal echoes due to the contribution of signals from surrounding tissues within the beam thickness. Recognizing slice thickness artifact is important because it can be mistaken for sediment, sludge, or pathology within a cystic lesion. To differentiate slice thickness artifact from true sediment within the bladder, simple method can be performed. By changing the patient's position or gently tapping the bladder with the probe, you can observe whether the echogenic material moves. If the echogenic particles shift with movement, it indicates true sediment like this image. However, if the echogenic appearance remains unchanged, it is likely an artifact caused by slice thickness. A small mass broadly attached to the dorsal wall of the bladder neck can be mistaken for a slice thickness artifact. In this case, careful evaluation is needed to differentiate between the two. Real masses maintain their shape and attachment to the bladder wall, regardless of probe angle or patient position. A true bladder wall mass typically has stronger echogenicity and well-defined margins. Artifacts, however, may change in appearance or disappear when adjusting the transducer angle or performing rescanning in a different plane. By recognizing these key differences, we can avoid misinterpreting an artifact as a pathological finding. Just like slice thickness artifact, side lobe artifacts can appear near fluid-filled structure. Ultrasound transducers emit a main central beam, and the transducers also emit weaker secondary beams called side lobes. These side lobes can interact with highly reflective structures, like the gas in the intestines. When the echoes from these off-axis beams return to the transducer, the machine incorrectly assumes they originated from the main beam's path, resulting in false echoes displayed inside an anechoic fluid-filled structure. They appear as low-level echoes inside anechoic structures, often mimicking sediment or linear structure, like this hyperechoic linear structure. This artifact lacks clear margins, unlike real structures. In the right image, the urinary catheter appears as a hyperechoic linear echo. However, its echogenicity is well defined, with strong and distinct echoes, differentiating it from an artifact. Now, let's talk about echo dropout artifact. It's an important artifact, but simple to understand. As the name suggests, this artifact refers to the loss of echoes, making certain areas appear anechoic or absent. Let's look at the patient with a large amount of peritoneal effusion. Ultrasound waves passing through fluid encounter the bladder wall at a specific angle. In some areas, the ultrasound beam may not return effectively to the transducer due to sound wave transmission and reflection. As a result, parts of the bladder wall may look thinned or absent, even though the structure is intact. This artifact should not be mistaken for bladder rupture. Let's take a quick clinical tip before moving on. If bladder wall rupture is suspected, especially when there is ascites around the bladder, making it appear discontinuous, ultrasound alone may sometimes be inconclusive. In this situation, we can determine whether the bladder is intact or ruptured by rapidly injecting agitated saline into the bladder, using a urethral catheter. If the bladder is intact, the echogenic saline will swirl inside the bladder, without leaking into the abdomen, like in this case. So, we can confirm that the bladder wall is intact. Consider using the agitated saline injection technique when evaluating a suspected bladder injury. From now, let's study two important artifacts related to color Doppler imaging. The first one is blooming artifact. This artifact occurs when a structure appears larger or more intense in color Doppler imaging than its actual size on B mode. It's due to excessive signal amplification. As a result, in color Doppler imaging, strong blood flow signals extend beyond the vessel walls, making the vessel appear larger than it actually is. As you can see here, compared to the vessel on B mode, the vessel in color Doppler appears enlarged. Therefore, when measuring lesion size, especially in vessels, always measure it on B mode rather than in color Doppler mode, to avoid overestimating vessel size. Now, let's move on to the last artifact in this series, twinkling artifact, which is another artifact related to color Doppler. On color Doppler images, you may see color signals from a structure that causes strong, irregular reflection due to beam scattering. This is known as twinkling artifact. It appears as a rapid alternation of blue and red colors, resembling turbulent flow, even though there is no actual blood flow. We can use this artifact to detect small stones, calcifications, or small metallic objects that might not be clearly visible on B-mode ultrasound. Let's take a look at this example. This patient has a prostate tumor, and as you can see, the prostatic parenchyma has undergone multiple cystic changes with internal hyperechoic areas. Now, look at the color Doppler image on the right. Do you see the strong twinkling artifact in this area? This confirms that this region represents a calcified lesion within the prostate. Now that we've gone through the 10 essential ultrasound artifacts, let's quickly review them together. Acoustic shadowing appears as a dark shadow behind stones, gas, or metal due to complete ultrasound wave attenuation. Edge shadows occur at curved margins of structures due to refraction. Be careful not to confuse it with acoustic shadowing. Reverberation artifact creates multiple evenly spaced echogenic lines behind gas or metal, often seen as comet tail or ring down artifacts. Acoustic enhancement makes the area behind fluid-filled structures, such as gallbladder, bladder, and cysts, appear brighter due to minimal attenuation. Mirror image artifact is commonly seen near the diaphragm, so don't confuse it with a diaphragmatic hernia. Slice thickness artifact and side lobe artifact can be seen in fluid-filled structures like the bladder, and make it appear to contain sediment, so be cautious not to misinterpret them as pathology. Echo dropout causes reduced echogenicity in the wall of fluid-filled structures, which can make the bladder or gallbladder wall appear thinned or disrupted. Avoid mistaking it for rupture. Blooming artifact occurs in color Doppler, making vessels appear larger than they actually are, so always measure vascular lesions in B mode for accuracy. Twinkling artifact helps detect small stones or calcifications that may not be clearly visible in B mode. If you suspect a small stone, check for twinkling on color Doppler to confirm. Understanding these artifacts is key to avoiding misdiagnosis and improving ultrasound interpretation. This has been Vet Image Lab. I hope this session has helped you see artifacts in a new light. If you enjoyed the lecture, don't forget to like, subscribe, and turn on notifications so you won't miss our next video. Thank you for joining me today, and I'll see you in the next lecture.